Don't let my residents ever hear this.
It gets your mojo going.
It does. It's fun.
Probably be big rimping.
It's a safe place here in the trust tree. I use inhaled sildenafil.
We're smoking like a rebel here.
Yes, we are.
Actually, lucitropy is a thing.
Hi, this is Jimmy Fair with Alcoholics Anonymous, and we are bringing you a new segment this time around. That is the 12-Step program, 12 Steps to Alcoholism, in contrast to an alcoholism 12-step program. We do not want to rid you of an addiction, but get you more addicted to echocardiography as a means to help your patients. The first step in our 12-step program is eyeball ejection fraction. So we're going to help you train your eyeball to accurately assess an ejection fraction in just moments with a couple views. Now, why do eyeball ejection fraction and not some quantitative method like fractional shortening or EPSS? Well, eyeball ejection fraction is quite useful, I think, for point of care purposes. It allows us to take into account a lot of the subtleties of an echocardiogram that would create false positives or false negatives with some of the quantitative methods. And as a general rule, when we have a quantitative method and it spits out a number, people like to latch on to the number and forget about a lot of the other information that's right in front of their face. And the eyeball EF kind of stresses the importance of taking in the whole picture and letting all of the information inform your impression of how well that left ventricle is performing. So, with that said, let's move on to 4 things that you want to pay attention to, or you want to train your eye to pay attention to when performing the eyeball EF. And the first thing is fractional shortening. What's fractional shortening? Well, all it means is how close do the endocardial walls approximate towards each other? What is the difference in the distance between the endocardial walls in diastole and systole? Myocardial thickening, how well does the myocardium actually thicken during systole? And is it circumferential or is only part of the myocardium squeezing? Annular movement, that is the valvular apparatus, does it move back and forth well as we see in the parasternal views, or does it move up and down well as we see in the apical views? And then EPSS, or E-point septal separation, that simply speaks to the mitral valve will open widely during diastole in a heart that has a normal ejection fraction, and that anterior mitral valve leaflet will get close to hitting the septum during diastole. The reason for that is if the heart squeezes out a lot of blood during systole, it then has to fill with a lot of blood during diastole, and when it fills with a lot of blood, it opens the mitral valve up widely during diastole. So those are the 4 things to kind of pay attention to as you're training your eyeball EF, and I think you'll get good at it quickly. Now, it is useful, I think, to have 4 general categories in order to lump eyeball EF into. Normal being an EF of 50 to 75%, hyperdynamic being an EF greater than 75%, mild to moderately decreased at the 30 to 50% range, and then the severely decreased less than 30%. And I think these are fairly useful clinical categories to keep in our minds. Let's try this out on some images here. So here we have a parasternal long axis. We see that the heart is squeezing well with the endocardial borders approximating well towards each other during systole, as well as we see good thickening of the myocardium. We see the mitral valve opening widely and almost touching the septum during diastole. And then we see the motion of the annulus or the valvular apparatus back and forth during systole and diastole. And if we take another look at the short axis view, again, we see good thickening of the myocardium and those endocardial walls approximating well towards each other. And if we look at the apical four-chamber view, again, we see that the annular movement is good up and down. We see good thickening of the myocardium, good approximation of those endocardial walls, and a nice wide opening of the mitral valve. And this all tells us that this is a very normal EF. Specifically, if we were to give it a number, it would be at 60% with the biplane Simpson's method, as was performed in this echo. Let's take a look at a bit of a different example. In this example, we see that in this parasternal long axis view, we see that the endocardial walls don't really approximate towards each other well. We don't see much thickening at all of the myocardium except for that inferolateral basal segment. The mitral valve does not appear to open widely, that anterior leaflet not getting anywhere close to the septum. And then lastly, that the annulus really doesn't move back and forth well. All these things point to a very poor ejection fraction, but we always want to confirm those findings in multiple views. So in the short axis, we again see similar findings. Very minimal thickening of the myocardium. We don't see good approximation of those endocardial walls. And we see all of those same things here in the apical four-chamber view that confirms our finding that this is indeed a severely decreased ejection fraction, and specifically at 20%. Now, there are some limitations to the eyeball ejection fraction method. Keep in mind that wall motion abnormalities are going to add a degree of complexity that's going to be somewhat difficult to account for. And when hearts are very tachycardic, sometimes people are prone to confuse that with hyperdynamic. Keep in mind, tachycardic does not mean hyperdynamic, and feel free to slow the image down to kind of avoid that error. Also, with tachycardia and arrhythmias, there's going to be limited time available or variable time for LV filling, and so there may be significant beat-to-beat variation in the case of arrhythmias. In the case of severe mitral regurgitation, keep in mind that a normal appearing ejection fraction does not necessarily reflect accurately the work that the left ventricle is capable of doing. In severe mitral regurgitation, about half of the blood volume is going retrograde into a low pressure system, and so that LV may not be capable of doing that much work, but it just happens to be pushing against low pressure for a lot of the work it's doing. And then also keep in mind that ejection fraction does not equal cardiac output. So in some cases, such as in significantly elevated right-sided pressures, perhaps in acute pulmonary embolism, you may have a very underfilled left ventricle. Well, if the left ventricle isn't filling very much, even though it might have an EF of 75%, its cardiac output might be quite low because it's not filling with a whole lot of blood, so it's not pushing out a whole lot of blood after it's filling. So keep those things in mind, but let's go ahead and commence with some practice. So what I've collected is a series of images, 2 or 3 images per echo, that have then had a quantitative biplane Simpson's method of accurately determining the EF. And then I'm going to show you the couple of images, and then I'd like for you to write down on a piece of paper both a number and a category. So try and give it a percent EF and also try and lump it into a category, either hyperdynamic, normal, mild to moderately decreased, or severely decreased. And see if you can get yourself fairly accurate here. So here's the first example. I'm just going to click through the first image and second image, and go ahead and write down your number and your category of what you think is going on. And this was mild to moderately decreased at 40%. Let's try the next example. All right, what do you think? Write it down, write a number and a category. All right, that was severely decreased at 16%. Next example. All right, what do you think? That was normal at 68%. Write it down, and you guessed it, hyperdynamic, 90%. And the final answer is normal, 59%. That one was normal at 52%. And you guessed it, severely decreased, 17%. Next example. And mild to moderately decreased, 36%. And again, mild to moderately decreased, 36%. What do you think? Mild to moderately decreased, 45%. That one a little bit tough with all of the wall motion abnormality going on. All right, what do you think? Normal, 61%. And write down your final answer. Hyperdynamic, 76%. Next example. What do you think? Moderate to severely decreased, right at 30%, right on the border. And write down your number in your category. Severely decreased, 26%. What do you think? Normal, 62%. You guessed it. Keep in mind, in this case, you could have been fooled by a bit of aortic regurgitation that was restricting that mitral valve leaflet from getting close to the septum if you were just paying attention to EPSS. Here's your next example. What do you think? Yeah, normal, 74%. Next example. And what do you think? Mild to moderately decreased, 31% on that one. So pretty close to severely decreased. And next example. All right, what do you think? Normal at 52%, so kind of low normal there. And thoughts? Severely decreased, 18%. Next example. What do you think? Severely decreased, 24%. Next example. Write down your final answer. Moderate to severely decreased, 32%. Next example. What do you think? Moderate to severely decreased at 33%. Kind of limited filling due to the tachycardia and arrhythmia in that scenario. Next example. All right, what do you think? Normal, 54%. Next example. And write down your answer. Mild to moderately decreased, 44%. What do you think? Mild to moderately decreased, 46%. And write down your answer. Normal at 56%. Again, with this, if you were just paying attention to the EPSS, you may have been fooled due to some aortic regurgitation. So always a good idea to put some color Doppler on your mitral and aortic valves to evaluate for abnormalities there. Next example. And what do you think? Normal at 58% there. And write down your answer. Normal 62%. And write down your answer. Normal at 72%. And that was all of them. So hopefully that was enough examples to get you a bit of practice. I do recommend whenever you have a patient that you have getting a comprehensive echo at some point, take a look at their echo. You don't have to look at the whole thing, but look at the parasternal long, parasternal short, apical 4, and come up in your mind with what you think the EF might be, and then look at the report and see how close you were with their more thorough quantitative method. And a little bit of practice in that, and your eyeball EF will be quite reliable and quite useful to your patients. So good luck with that. Thanks for tuning in.